Good morning, everyone. I'm Dr. Asim Hussein, and I'm pleased to welcome you today. We'll be exploring methemoglobinemia and how to interpret related data. This is the first slide of our presentation, so I just want to set the stage. We'll cover the basics of the condition, how to recognize it, and what the data tells us. Let's get started and delve into this important topic together. All right, so today we're looking at a 75-year-old patient who's just come into theater recovery following a wide local excision and axillary node clearance for breast carcinoma. The patient was doing well before the operation, which is always reassuring, but during the 90-minute procedure, she started to become hypoxic. She was successfully extubated, which means her airway was clear enough to remove the tube, but now her oxygen saturations are reading around 85%, which is definitely concerning. The rest of her vital signs are within normal limits, so her blood pressure, heart rate, and temperature are stable, but her oxygen levels are not. So what's our approach here? Well, first, we need to think about the possible causes of hypoxia in this context. It's crucial to systematically evaluate and identify whether the problem is related to the airway, lung function, or other factors. This scenario highlights the importance of continuous monitoring and being alert to changes after surgery, especially in patients with recent thoracic or breast procedures. It also reminds us that even if the initial extubation was successful, complications like hypoxia can still occur and require prompt assessment and intervention. Understanding these key points helps us connect to the broader theme of postoperative respiratory management and ensuring patient safety in the recovery phase. All right, let's move on to some key initial steps. First, it's crucial to check the airway, ensure the patient is breathing properly, and that circulation is intact. Once you've done that, provide 15 liters of oxygen using a non-rebreather mask to optimize oxygenation. Next, take a thorough history and conduct a physical examination to gather all relevant information. This helps in understanding the underlying cause. After that, checking arterial blood gases is essential to assess oxygenation and ventilation status. Finally, order a chest X-ray. The goal here is to rule out common causes such as airway compromise, hypoventilation, residual neuromuscular block, atelectasis, or pneumothorax. These steps are all about quickly identifying and managing potential life-threatening issues. Let's look at this chest X-ray. First, the heart size appears normal. It's not enlarged, which is a good sign. This suggests there's no cardiomegaly or heart failure contributing to her symptoms. Next, I don't see any lobar collapse or consolidation, so no signs point to pneumonia or other infections causing lung issues. There's also no gross pulmonary edema, which means fluid isn't filling the lungs in a way that would indicate heart failure or other problems. Additionally, there's no pleural effusion, so no fluid buildup around the lungs that could cause breathing difficulties. The major pulmonary vessels at the hilum also look normal, which is reassuring because it suggests no major vascular pathology like a pulmonary embolism affecting blood flow. Overall, this X-ray gives us a clear picture, no obvious structural or fluid abnormalities. So based on this, what do you think might be causing her symptoms? Let's look at the results of a subsequent blood gas taken in theater recovery, while she's on 60% FiO2. Despite this increased oxygen, her saturations are still low at 85%, which is concerning. Her pH is 7.38, indicating that her acid-base status is fairly normal at this point. The PO2, however, is 31.1 kPa, which is quite high and suggests she's receiving a significant amount of oxygen, but her oxygen saturation isn't reflecting that. Her PCO2 is 4.6 kPa, which falls within the normal range, indicating she's ventilating adequately. The base excess is 1.1 mx/L, suggesting there's no significant metabolic acidosis or alkalosis. Lastly, her lactate is 1.9 mmol/L, which is slightly elevated but not alarming, indicating her tissues are still managing okay without significant hypoperfusion. Overall, these results tell us that despite good ventilation and oxygen delivery, her oxygen saturation remains low, so we need to consider other factors, like shunt or diffusion issues, to understand her ongoing hypoxemia. So let's talk about how we would calculate her alveolar, arterial, or A oxygen gradient. First, it's important to understand that this gradient helps us assess how well oxygen is transferring from the lungs into the blood. To calculate it, we need to determine the alveolar oxygen tension, which we call PaO2, and then compare it to her arterial oxygen tension, or PaO2. For PaO2, we typically use the alveolar gas equation. This involves the inspired oxygen concentration, the atmospheric pressure, her arterial carbon dioxide level, and some constants. Specifically, we take the inspired oxygen fraction, subtract the partial pressure of water vapor, and then adjust for her CO2 level, which influences alveolar oxygen. Once we have PaO2, we subtract her measured PaO2 from it. The resulting difference is the alveolar, arterial gradient. A normal gradient suggests efficient gas exchange, while an increased gradient indicates potential issues like ventilation perfusion mismatch or diffusion defects. Understanding this gradient is crucial because it helps us pinpoint where the problem lies in oxygen transfer. Is it in the alveoli, the blood, or somewhere in between? It becomes especially valuable when we're trying to differentiate between various causes of hypoxemia. So, in essence, calculating and interpreting the a gradient provides us with a window into the lungs' ability to oxygenate blood properly, which ties directly into the overall goal of evaluating respiratory function and guiding our management. Let's walk through how we calculate the alveolar arterial oxygen gradient. It all starts with the alveolar gas equation, which is PaO2 equals PiO2 minus PaCO2 divided by R now. PaO2 represents the partial pressure of oxygen in the alveoli, and PiO2 is the partial pressure of inspired oxygen. PiO2 is determined by multiplying the fraction of inspired oxygen, or PiO2, by the difference between atmospheric pressure and water vapor pressure. At sea level, atmospheric pressure is about 101 kilopascals, and water vapor pressure is roughly 6.3 kilopascals. Next, PaCO2 is the partial pressure of carbon dioxide in arterial blood, which tells us about CO2 elimination. And R is the respiratory quotient, typically around 0.8, representing the ratio of CO2 produced to oxygen consumed. Once we have PaO2, we can find the a oxygen gradient by subtracting the arterial oxygen partial pressure, PaO2, from PaO2. This gradient helps us identify underlying issues. A high a gradient suggests there might be problems with ventilation or perfusion, like a mismatch, or even a shunt, where blood bypasses the lungs without getting oxygenated. And importantly, the normal a gradient tends to increase with age, so age considerations are also part of our assessment. So, understanding this calculation helps us evaluate how well oxygen is transferring from the alveoli into the blood, which is central to diagnosing and managing respiratory conditions. Her a gradient is not unduly high. So, what do you think might be going on here? What could be causing this? Well, first, it's important to understand that a normal a gradient suggests that the lungs are efficiently transferring oxygen from the alveoli into the blood. If it's not high, it generally indicates that the oxygen exchange isn't significantly impaired. However, if the patient is hypoxic despite this, we need to consider other factors. For instance, maybe the issue isn't with the alveolar capillary interface, but with hypoventilation or low inspired oxygen levels. Or perhaps there's a ventilation perfusion mismatch that's subtle or localized. The key point here is that since the a gradient isn't elevated, we can start ruling out some causes like significant shunt or diffusion defects. But we still need to look at the overall clinical picture and other diagnostic clues to pinpoint the exact problem. So, understanding the a gradient in context helps us narrow down our differential diagnosis and guides our next steps in management. In this case, she has methemoglobinemia, which was caused by the use of a dye during the procedure to help locate the lymph nodes. This dye can sometimes lead to this condition. The key point here is that the low oxygen saturation readings we see are actually due to the absorption spectrum of methemoglobin, which is detected on pulse oximetry. Essentially, the dye alters the way oxygen levels are measured, making it look like there's a problem with oxygen, when in fact it's a different form of hemoglobin. This highlights the importance of understanding how certain dyes or substances can interfere with our monitoring tools and affect our interpretation of a patient's condition. It's a good reminder to always consider the context behind abnormal readings, especially in surgical or procedural settings. So, how would I confirm a diagnosis of methemoglobinemia? Well, first, it's essential to look at the clinical picture. Patients often present with cyanosis that doesn't improve with oxygen therapy, and they might have symptoms like shortness of breath or fatigue. But to definitively confirm it, the key test is measuring the level of methemoglobin in the blood. This can be done through co-oximetry, which is a special type of blood gas analysis that accurately quantifies different hemoglobin species, including methemoglobin. Additionally, it's useful to compare the oxygen saturation readings from pulse oximetry with the arterial blood gas results. In cases of methemoglobinemia, you'll often see a discrepancy, where pulse oximetry shows low oxygen saturation, but the blood gases indicate a normal or near-normal partial pressure of oxygen. The overall goal here is to correlate the clinical findings with specific laboratory tests, because this helps us confirm the diagnosis and determine the severity. Recognizing these signs early and confirming with accurate testing is crucial for guiding appropriate treatment and improving patient outcomes. Let's walk through the key steps for confirming a diagnosis of methemoglobinemia. First, we need to confirm the diagnosis itself. This involves performing an arterial blood gas test, which is essential in this context. When we analyze the blood sample using a co-oximeter, we look specifically at methemoglobin levels. Elevated methemoglobin levels on this analysis are a strong indicator that the patient indeed has methemoglobinemia. This step is crucial because it provides objective, quantitative data that supports our clinical suspicion. Remember, accurate diagnosis at this stage guides us toward the appropriate treatment plan and helps us understand the severity of the condition. So, to sum up, confirming the diagnosis hinges on the arterial blood gas test with co-oximetry, which reveals elevated methemoglobin levels. This is the cornerstone of our diagnostic process. So, let's explore some of the other known causes of methemoglobinemia beyond the usual suspects. It's important to recognize that this condition can sometimes be triggered by various factors, not just exposure to certain drugs or chemicals. For instance, some medications like local anesthetics, particularly prilocaine and benzocaine, are known to cause this issue if used improperly. Additionally, certain chemicals and environmental toxins, such as nitrates and nitrites found in contaminated water or processed foods, can also lead to elevated levels of methemoglobin. These substances are converted in the body to compounds that interfere with hemoglobin's ability to carry oxygen effectively. It's also worth noting that some congenital conditions, though rare, can predispose individuals to develop methemoglobinemia. These are inherited enzyme deficiencies that impair the body's ability to reduce methemoglobin back to hemoglobin. Understanding these causes is crucial because it broadens our perspective beyond the typical scenarios. Recognizing these factors helps us identify at-risk patients more accurately and underscores the importance of thorough history-taking in clinical practice. This ties back to our overall theme of early recognition and effective management of this condition. Let's take a closer look at methemoglobinemia. It can actually be either congenital or acquired. When we talk about the congenital form, it's usually due to a deficiency in cytochrome B5 reductase, an enzyme that plays a vital role in maintaining hemoglobin in its functional state. On the other hand, the acquired form happens due to exposure to certain substances or drugs. Some of the common culprits include nitrates, which are often found in contaminated water or certain foods. Then, there are local anesthetics like prilocaine and benzocaine. These are used in various medical and dental procedures, but they can sometimes trigger this condition. Certain antibiotics, such as dapsone, are also known to cause it. Additionally, exposure to aniline dyes, which are used in manufacturing processes, can lead to acquired methemoglobinemia. Understanding these causes is important because it helps us identify and manage the condition effectively, especially when patients present with cyanosis or unexplained hypoxia. Recognizing the difference between congenital and acquired forms guides us in choosing the right treatment approach. Let's take a closer look at the underlying pathophysiology of methemoglobinemia. Normally, hemoglobin in our red blood cells contains iron in the ferrous state, which is Fe2+. This form of iron is essential because it allows hemoglobin to effectively bind and release oxygen throughout the body. In methemoglobinemia, a key problem occurs. The iron in hemoglobin gets oxidized from Fe2+ to the ferric state, Fe3+. This oxidized form is called methemoglobin. Unlike normal hemoglobin, methemoglobin cannot bind oxygen efficiently. This shift results in a decreased oxygen-carrying capacity of the blood. Even though oxygen might still be present in the lungs, the presence of excess methemoglobin means less oxygen reaches the tissues. Furthermore, the body has some mechanisms to reduce methemoglobin back to functional hemoglobin, primarily through enzymes like cytochrome B5 reductase. However, when these reduction pathways are overwhelmed, due to toxic exposures or genetic deficiencies, methanemia develops and causes clinical symptoms. Understanding this process is crucial because it explains why patients with methemoglobinemia often present with cyanosis and hypoxia, despite having normal oxygen levels in their blood gases. It underscores the importance of the oxidation-reduction balance in maintaining proper oxygen transport. Let's take a closer look at what happens during this process. The answer, quite simply, is that the ferrous ion, which is Fe+2 and found in heme, gets oxidized to its ferric state, Fe+3. Now, this change is really important because Fe+3 ions have a poor affinity for oxygen. Basically, they don't bind oxygen very well. What's interesting here is that the remaining ferrous ions, the Fe+2, actually end up with an increased affinity for oxygen. This shift causes the oxygen dissociation curve to move to the left. And why does that matter? Well, a left shift in the curve means that hemoglobin holds onto oxygen more tightly. So, even if oxygen is available, hemoglobin is less willing to release it to tissues that need it. Overall, this process results in reduced oxygen delivery to tissues, which can have significant effects on tissue oxygenation and function. It's a crucial concept to understand when considering how hemoglobin functions under different conditions. So, let's talk about the clinical features you might observe in a patient with methemoglobinemia. Now, remember, this condition results from an abnormal form of hemoglobin that can't carry oxygen effectively. As a result, patients often present with a characteristic cyanosis, which is a bluish discoloration of the skin and mucous membranes, even when their oxygen levels are not critically low. You might also notice symptoms like fatigue, weakness, and shortness of breath, especially with exertion. In more severe cases, neurological symptoms such as dizziness, headache, or even confusion can occur due to inadequate oxygen delivery to the brain. It's important to highlight that these clinical features are directly linked to the impaired oxygen transport caused by the abnormal hemoglobin. Recognizing these signs early is key because it helps us differentiate methemoglobinemia from other causes of hypoxia and cyanosis. Overall, understanding these features allows us to connect the dots within the broader context of diagnosing and managing this condition effectively. Let's take a closer look at how symptoms relate to the level of methemoglobin in the blood. As you can see, the symptoms are proportional to the fraction of methemoglobin present. Normally, the methemoglobin fraction is about 1%, with a typical range of 0 to 3%. When levels are higher, different symptoms emerge. For instance, at levels between 3 and 15%, you might notice slight discoloration of the skin, which can appear pale, gray, or even bluish. Interestingly, at this stage, patients may still be relatively asymptomatic, meaning they might not feel any noticeable symptoms. Moving up to 15 to 20%, cyanosis becomes more apparent, that bluish tint of the skin, and again, patients might not experience significant symptoms despite this visible change. As the levels reach 25 to 50%, symptoms become more pronounced and concerning. Patients often experience headaches, shortness of breath, lightheadedness, weakness, confusion, palpitations, and chest pain. These are signs that the oxygen-carrying capacity of the blood is significantly impaired. When methemoglobin levels rise to 50 to 70%, the situation becomes more critical. You can see abnormal cardiac rhythms, altered mental status, delirium, seizures, and even coma. Profound acidosis can also occur at this stage, which indicates severe disturbance in the body's acid-base balance. Finally, at levels above 70%, the prognosis is grim, and death is usually imminent. It's important to remember that individuals may be asymptomatic, especially if their levels are below 15%. So, sometimes, the absence of symptoms doesn't necessarily mean everything is fine. Levels can still be dangerously elevated without obvious signs. This highlights the importance of monitoring methemoglobin levels in suspected cases and understanding how the symptoms correlate with the degree of poisoning. So, when it comes to treating methemoglobinemia, there are a few key points to keep in mind. The primary treatment is the administration of methylene blue, which acts as an artificial electron transporter. This helps to reduce the methemoglobin back to functional hemoglobin, restoring the blood's ability to carry oxygen effectively. It's also important to consider supportive measures, such as providing supplemental oxygen to help improve tissue oxygenation while the treatment takes effect. In some cases, especially if the patient has a G6PD deficiency, methylene blue may not be suitable. Alternative treatments like high-dose ascorbic acid can sometimes be used, although they are less effective. Overall, the main goal is to quickly reverse the abnormal form of hemoglobin to prevent tissue hypoxia and associated complications. So, prompt recognition and appropriate treatment are crucial in managing methemoglobinemia effectively. Let's go over the key management strategies for this condition. First, administering supplemental oxygen is essential. It helps improve oxygen delivery to tissues, especially when hemoglobin function is impaired. Next, intravenous methylene blue plays a crucial role as a specific antidote. It works by facilitating the reduction of methemoglobin back to normal hemoglobin, effectively reversing the poisoning. It's also important to note that the roles of hyperbaric oxygen therapy and exchange transfusion are mainly anecdotal at this point. While they may be considered in certain cases, there isn't solid evidence supporting their routine use. Overall, prompt oxygen therapy combined with methylene blue is our mainstay in treatment. These approaches help mitigate the hypoxia caused by compromised hemoglobin function and are central to managing this condition effectively. So let's talk about what other types of dyshemoglobinemias can cause spurious results with pulse oximetry. As we've seen, abnormal hemoglobins can interfere with accurate oxygen saturation readings. But beyond the most common ones, there are several other variants. These abnormal hemoglobins can distort the spectral properties that pulse oximetry relies on, leading to falsely high or low readings. For example, hemoglobins like methemoglobin or carboxyhemoglobin can significantly impact the measurements. Recognizing these potential pitfalls is important because it helps us avoid misinterpreting a patient's oxygen status, especially in critical care settings. It reminds us to always consider the clinical context and possibly confirm with alternative methods when results seem inconsistent. Ultimately, understanding these limitations is key to providing accurate assessment and safe patient care. Let's look at some other examples of dyshemoglobinemias that can lead to spurious results. These include carboxyhemoglobin and sulfhemoglobin. Both of these forms can interfere with accurate measurements because they alter the usual hemoglobin readings. It's important to be aware of these, especially in cases where results don't match the clinical picture. Recognizing these potential interferences helps us avoid misinterpretation and ensures we provide the best care for our patients. This highlights the importance of understanding different hemoglobin variants and their impact on laboratory results within our overall management strategy. Thank you so much for your time and attention today. I really appreciate the opportunity to share these insights with you. Remember, the key points we've discussed highlight the importance of understanding the core concepts and how they connect to the bigger picture. I hope you found this presentation valuable and that it inspires you to take the next steps forward. Once again, thank you for being here and for your engagement throughout.